later. Now, adverse events are for other reasons. Look at renal insufficiency and stroke are the two problems that we deal with, especially if something is hypertensive, an older patient, renal insufficiency, this is an issue. And this affects most of us. As you move around the arch into these patients with arch disease, it is a problem for their treatment. From the transection standpoint, 4 patients at 1 month had cerebrovascular accidents. Sometimes it's hard to look at the cervical Willis and the cerebrovasculature in terms of whether you're left avert dominant or not, and this can lead to these cerebrovascular accidents. So you do have to be very careful about enrolling patients. And as I mentioned, 1 patient was enrolled with spinal cord ischemia and 1 developed it, and that got our 2 patients with that issue. In terms of the patients enrolled in the ruptured aneurysm arm, pulmonary complications the most. As you imagine, blood in the left chest is a problem, and dealing with this is a little bit of an issue. So most people approach this as fix the aneurysm, exclude it, and then drain the hemothorax as much as possible. We do have arterial complications still in emergencies. It's less easy to plan the access, as Scott Stevens said, and it's still 15%. And most studies are probably in the range of 15 to 20%. And Anthony Lee is going to talk about that in his complication talk. Other key factors, as you look at it, 4 conversions after the trial, 2 in the dissection patients for rupture of the arch and the dissection itself. 1 compression issue where the trauma of the device was causing obstruction of the aorta, and then 1 fistula in the rubbing rupture in the fistula group. We needed 6 additional procedures to help out these patients with implants because of endoleak or persistent flow, which were corrected. But in summary, if you look at this small group, you can tell that early mortality was halved compared to open surgical controls, and the incidence of paraplegia for dissections was 0. And compared to the surgical literature, dissection repairs have a higher paraplegia incidence than aneurysm repair, but just the opposite for endovascular repair. Most of us experience less paraplegia for dissection patients. Trauma, combined mortality and paraplegia of 10%, but there is a benefit over open surgical repairs. Most of the studies have shown, although we have no long-term data about this particular role. And then the ruptures, lower mortality, over half compared to open surgical, but poor long-term survival, reflecting the other comorbid problems these patients have. So really, where do we go from here? This is a picture of the modified TAG device. Now this device has been modified to actually make it more disease-specific treatments. The same device doesn't exist for every size. There are differences in the device in terms of how it performs, in terms of what we say is hugging the inner curve or its conformability. And so on the left is the old device, and this is the new device. They've eliminated the flares and gone with more apices in the sinusoidal passage, which helps it stick to the inner curve. It's a single stent. And the wire diameter is dependent upon the treatment range. And the reason being, as you think about it, the older patients have larger aortas. They don't need the same amount of radial force on the device as the smaller devices which go in younger patients, where it's a much more hostile environment in terms of stress forces on the device. So they've modified this wire over the range, and so you can then select the device that's best fit for your patient. Now, if you look at it, here's the chart, which is a little harder to understand, I think, but the 2 important parts are, 1, they have smaller devices now, and we have tapered devices. So 2 additional types of devices. And what does that translate into? Well, if you look at the old device, if you had a 23 millimeter aorta, for instance, you chose a 26. If you had a 24 millimeter aorta, you could choose a 26 or 28, but if it's 24.1, you only had 1 device. So it's a very narrow range for each of these different device sizes. Now, if you look at the new device, at a 45, look, we can still treat the same maximal diameter, but instead of looking at a 37 millimeter aorta, we can take that down all the way to 33. So the surgeon or the interventionist at any point can choose between 1 of 3 devices many times. If I choose, in other words, 29 millimeter aorta, I have 1 of 3 different devices to choose from. If it's an old patient that just happens to have a small aorta, I can choose something that's better in terms of handling oversize, which is more likely going to treat an aneurysm. If it's a young patient, I want something with a more radial force, which is going to be a 31 device. So I can then tailor the treatment to the patient's disease that he has, not that all patients with thoracic disease are the same anymore. It's different than infrarenal disease. So if you look at the current trial, the GORE-OA trials, disease-specific trials that are now being conducted in the U.S., 3 trials. All 3 trials are open. The TAG 0801 is a dissection trial. It is enrolling patient. The TAG 0802 is a blunt aortic injury trial, and its first patient was enrolled in December this year. And the TAG 0803 trial is a aneurysm patient, and its first enrollee was in October. This is one of the patients at our institution enrolled in the aortic transection, 30 years of age. So this is the new device, a very tight curve. This is what Scott showed. The device tends to sit up, and you have to fix this problem. If it sits up, it may collapse. It may not exclude deletion. This is the placement of the device. You see it's right on the curve. There is no lift of this device off of that, and we've covered the left subclavian as necessary. Now, if you compare that old versus new, this is what the old device would look like in this position. This is the new device that sits right along the inferior curve. So it has performed in the patients we've implanted as that was designed by the engineers and has made a big difference. This is the device that I implanted. Here you see end on, no collapse. The device looks very good, completely open. The old device, if you oversized it wrong, you would get a C-shaped problem like this. So the device now performs well. This was actually a tapered device that we inserted, which really helped both the top and bottom end look fine. There are other U.S. trials. There are dissection trials being conducted by Cook. Medtronics is not open yet, but will be open, and Bolton Medical has one planned. And from a transection standpoint, all the other three device manufacturers that are marketing in the U.S. are planning transection trials, but they're not yet open. I think that you have to be careful. Just because you have a hammer, everything is not a nail. This is a young patient. When she saw me in 2006, she was 37. She'd had a type A repair with residual false lumen, and so the false lumen was patent all the way down to her iliacs. She really came to see me for two reasons. She had a 4-centimeter diameter thoracic aorta, the proximal part, and had severe left leg claudication. And if you look at her study, she had stenosis where the true and false lumen at the iliac re-entered. And so the question is what to do about that, because if you shut this down and she had an entry point up here, it may be a problem, may pressurize it, and she may get worse, not better. So we did some studies, and really what she needed was an left iliac stent, because that was the only place that blood flow was going in on a dynamic study. It was coming in this area and going up. So we put a left covered iliac stent, and if you look what happened to her the following year, she starts to thrombose all this upper area. And this is patent down here in thrombosis and thoracic aorta. If you look at 2008, and now I saw her 2 weeks ago, 2009, she's thrombosed the whole thing except two areas, one right here above her celiac and one right here to the left renal where she has a small communication. But her aorta now is completely healed in the top end. So everything doesn't need to be a thoracic stent graft. I think you need to examine these patients and understand the pathophysiology going on and where the pressurization is coming from. I hope that she'll never need a thoracic stent graft. And we'll continue to follow her. So TEVAR devices outcomes differ with varying pathology. Compared to traditional open surgery, early outcomes really appear to be very promising. However, there are no mid and long-term results, and those remain to be proven in all of our series. Thank you.